we just ended talking about interventions, and now we're going to talk about interventions to reduce poor air quality. Robyn Traynor from McMaster and the National Collaborating Center for Methods and Tools has just finished a detailed review of this topic. So we're really pleased to have you join us, Robyn. Take it away.
Great. Thank you so much. I trust you can see my slides and you can hear me.
You're great.
Yes, we can.
Perfect. All right. So good morning, everyone, and thank you for having me and for accommodating me and my virtual attendance. I'm joining today from Halifax, Nova Scotia, where 2023 certainly marked our province's most devastating wildfire season on record. So I, like everyone in this meeting, feel personally invested in this topic. As you just heard, my name is Robyn Traynor. I'm a knowledge broker with the National Collaborating Center for Methods and Tools, which is led by our scientific director, Dr. Maureen Dobbins. What I want to share today are the results of a rapid systematic review that Maureen and I led on the effectiveness of public health interventions on reducing the health impacts of wildfires. In terms of disclosures, I have none. And while I'm in Nova Scotia, the National Collaborating Center for Methods and Tools is actually hosted by McMaster University in Hamilton, Ontario. And McMaster recognizes and acknowledges that it's located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So quite quickly here, my organization is one of 6 national collaborating centers located across Canada. For those who may be unfamiliar with our centers, we were established in 2005 and are funded through the Public Health Agency of Canada. So collectively, our centers work to strengthen and support public health across the country, with each center focusing on a different public health priority area. So you can see here that includes Indigenous health, infectious disease, determinants of health, healthy public policy, and environmental health. And actually, the review that I'm presenting today was produced through a collaboration with our sister center here in BC, or there in BC, I should say, the National Collaborating Center for Environmental Health. But at the National Collaborating Center for Methods and Tools, our focus is to support and scale evidence-informed decision-making in public health organizations in Canada. So we provide high-quality resources, real-world training, and practical mentorship that responds to the ever-evolving needs of public health. And I'll have an example of how we've evolved on the next slide. Our vision is stronger public health driven by the best available evidence to improve health and well-being. So 2 of the models that guide our work are pictured here. The first, pictured on the left, is what we call the what. And this model acknowledges that public health decisions are complex and they're informed by a variety of types and sources of evidence, so not just research evidence. And then the how, which is pictured on the right, which are our steps to systematically incorporate evidence into the decision-making process. So what I'll highlight today is how we looked at the research evidence and 4 of the steps that are on, we call this a wheel, it's on this wheel. So define, search, appraise, and synthesize through a rapid evidence review process. So we established our rapid evidence service in 2020 to support the public health sector's response to the COVID-19 pandemic. So at that time, of course, there was a rapidly growing and evolving body of COVID-related evidence. And public health decision makers were tasked with making decisions based on all of that changing evidence that was of variable and sometimes questionable quality. And then perhaps more than usual, these decision makers were stressed by time and human resource constraints. So there was this urgent need for synthesized and appraised evidence. And to help address this need, we moved away from our focus on training and support to actually conducting the syntheses ourselves. So we developed an approach, this is our rapid evidence service, based on internationally accepted rapid review methodologies. We were originally geared towards responding to public health decision makers' requests for evidence on COVID, but are now open to all priority public health questions as our capacity allows. And the icons here on the right are a selection of some of the topics that we've addressed. Another component of our service is that we've introduced a citizen engagement component where we include public and patient partners at different points along the process to enhance the relevance and responsiveness of our reviews. So speaking of that process, very briefly, our rapid reviews follow those 4 steps I already mentioned. First, defining that priority question and establishing our detailed inclusion and exclusion criteria, conducting our comprehensive database search with supplementary search methods as needed, and then screening the studies for relevance, critically appraising the included studies using validated tools, and then summarizing the key findings, weighting the certainty or the confidence of those findings using a grade approach, and then narratively synthesizing all of our results then into an overview of the evidence with key points and knowledge gaps. There are a couple links here on the screen if anyone would like to see. We have a paper published on our methods, and then the link to access the completed reviews on our website. Which of course brings me to the review I want to talk about, which is on the effectiveness of public health interventions on reducing the health impacts of wildfires that we published this fall at the end of October. So in terms of background for this question, we know that exposure to wildfires and their smoke has a well-established impact on the health of populations, from direct physical and mental health implications to more indirect environmental and socioeconomic consequences. So the role of public health in responding to and mitigating these risks varies across jurisdictions, but typically involves multi-sectoral collaboration, community engagement, and the use of diverse sources of evidence, as I showed on an earlier slide with our model of the different sources of evidence. So specific actions and interventions to respond to and reduce the negative impacts of wildfire smoke events have included things such as establishing air quality monitoring systems and cleaner air shelters, providing masks or recommending their use, issuing evacuation orders, and offering mental health and socioeconomic supports and resources. But what we don't know, or what is less understood, is whether these public health interventions are effective. So this rapid review then addressed the question, what is the evidence for the effectiveness of public health interventions and their potential unintended consequences to reduce the direct and indirect health impacts of exposure to wildfires, including wildfire smoke and combined heat wildfire smoke events? So a little bit wordy, let's break that down. Here you can see our detailed inclusion and exclusion criteria. We used a PICO format to form our question. So that means population, intervention, comparisons, and outcomes, as well as we excluded certain study designs. So at the population level, we were interested in public health units, policy and decision makers at all levels of government, and communities in OECD countries. We included interventions or policies that aim to mitigate the effects of wildfires specifically on the community. So we weren't interested, you can see in our exclusion, we weren't interested in wildfire prevention or resource allocation in response to wildfires. And then really importantly, when we talk about the outcomes, is that the included studies needed to be evaluating the impact of these interventions on either direct health impacts, which we were defining as including outcomes such as respiratory and cardiovascular health, injuries such as burns that came directly from the fire, and mental health, or indirect impacts. So here I'm talking about environmental and socioeconomic impacts. So in terms of our search strategy, then we searched for evidence available up to about the end of July. So July 27th was the day we conducted our search, and we searched these databases from inception. So basically we had no limitations on our search dates. We looked in these databases that we have listed here, as well as preprint servers. And then we ran additional searches of those reference lists. So either of the included studies, any study that we included, we checked its reference list to see if we had missed any, and in any reviews or reports that didn't meet all of our inclusion criteria for that review to be included, but were still relevant to the general topic. So we searched those reference lists as well. And then we also had input from a subject matter expert from the National Collaborating Center for Environmental Health to help us to identify key studies and to ensure that we had identified all the key studies. The next step was to look at and appraise the quality of these studies. So the methodological quality of the studies was assessed by 2 reviewers using critical appraisal tools that were appropriate to the study design of the included study. And we used the checklist from the Joanna Briggs Institute. Then any data that was relevant to the research question. So here we're talking about the study design, details about the setting, the population, the interventions, and the outcomes were extracted. You can see all of these details in our final report, and then synthesized narratively. So again, a subject matter expert from the National Collaborating Center for Environmental Health reviewed and provided feedback on our synthesized results. I think what was really unique about this review too is that it included both quantitative and qualitative research evidence. So we adapt the grade approach to assess the overall certainty in the quantitative findings and the overall confidence in the qualitative findings. To assess the certainty in quantitative evidence, we applied the grade criteria where different study designs. So for example, an observational study begins at a low certainty of evidence, and an experimental study would begin at a level of moderate. And then these can be further downgraded or upgraded based on the 8 criteria here on the slide. So risk of bias, inconsistency, indirectness, imprecision, other biases like publication bias, effect size, a dose-response relationship or presence of one, and confounding. And then on the qualitative side, to assess the confidence in the findings of the qualitative evidence, we applied what's called grade sur qual, where qualitative research begins at a high level of confidence and can be reduced based on these 4 levels. So limits in the methods, relevance, coherence, and adequacy of the data. So then the overall certainty and confidence were then factored into our conclusions, as you'll soon see. So let's get to those conclusions now. So in terms of our results, this review included 19 single studies of moderate to high quality, describing the effectiveness of public health interventions to reduce the health impacts of wildfires and their smoke. So specifically, the evaluated interventions were related to improving indoor air quality, communicating outdoor air quality, executing evacuation orders, and evaluating a multi-component intervention that was looking at a combination of masking, evacuation, air filtration, and public service announcements. So that's what our review included. And given the topic and the theme of today's workshop, we'll begin with the key findings that are related to indoor air quality. So most of the studies reporting on indoor air quality included air filtration interventions, highlighting findings for both unfiltered and filtered conditions. As has been established in previous presentations today, while not the same, indoor air quality is likely impacted by outdoor air quality. So when the outdoor air quality is poor, unfiltered indoor air quality is also likely poor. The amount of infiltration may depend on factors related to the indoor environment, such as building type, the number of windows, the air exchange rate, the behaviors of the building's occupants. And I know that this point also echoes a previous speaker's comments on the potential disparities in infiltration factor, depending on the building itself. So then remaining indoors without air filtration likely does not provide sufficient protection during smoke events, particularly for high-risk populations. That was one of the findings that we came across in the studies that we included, but the certainty of evidence is low according to the grade approach, and this means that findings may change as new evidence becomes available. So it's important to keep that in mind as we consider these findings. But continuing on this theme then, filtering or cleaning the air by using filters on a central HVAC system or portable air cleaners has been shown to likely reduces indoor particulate matter concentrations. And there was some evidence in the studies that HEPA filter use may have a greater impact on reducing these concentrations. Again, though, the certainty of evidence was low. So as I said, I know today's workshop is all about the indoor environment, but I did want to highlight some other key findings in our review as well. So with respect to communicating outdoor air quality, the included studies showed that wildfire smoke forecasting and air quality health indices may be predictive of respiratory health indicators, with implications for use then as an early warning system and possibly as an indicator for other interventions. So, for example, when to issue evacuation orders. The certainty of the evidence here, though, was very low. So we say then that findings are likely to change as new evidence emerges. And then with respect to evacuation orders, and if you recall from our first speaker's presentation, I think he said that over 232,000 people were evacuated in Canada in 2023. So these findings are really important to consider as well. When executing community-wide evacuation orders, these may negatively impact mental health, including increased rates of stress, anxiety, and depression among those who are evacuated, and then limited access to information about the evacuation and access to healthcare, prescription medications, and mental health supports may result in a greater unmet need and uncertainty among those who are evacuated. So the certainty of evidence here was also very low, something to consider when we look at these findings. Carrying on with the evacuation order findings, evacuation orders have had varied impacts on different individuals. So the included studies showed that female evacuees may experience higher rates of anxiety and depression. As well, female evacuees and those with mental illnesses may have more confusion around and difficulty finding information related to the evacuation. Another consideration was the destination. So the evacuation destination may have a differential impact on anxiety. So thinking about when people are evacuated, are they going to a friend's place? Are they staying with their families or within their communities? Or have they been separated and they've gone to different places like motels or other zones like that? The certainty of evidence here was also very low. Now, what was interesting was that I said that the review included both quantitative and qualitative studies, and the findings from the qualitative studies really corroborated what we saw in the quantitative results. So here we saw that negative consequences of evacuation experiences, so such as fear, uncertainty and confusion, anxiety, financial losses, they were reported more frequently than positive outcomes. We also saw that these consequences may have enduring and varied impacts on different populations, again, stressing the importance of communication and preparedness. And that relocating evacuees together may offer opportunities to strengthen cohesion, altruism, and support within the community. So the findings here, the confidence of evidence was moderate. So findings are likely a reasonable representation of the phenomenon of interest. And then the fourth thing to highlight here was multi-component intervention. So the evidence had very low certainty about the impacts of a multi-component intervention, specifically when looking at respiratory symptoms. So this intervention was involved HEPA use, mask provision, public health messaging, and evacuation support. And the study found that only HEPA use and recalling a public service announcement related to the wildfire risk were associated with decreased odds of reporting a worsening respiratory symptom. And another intervention that was looking at using a mobile app, combining air quality, smoke, wildfire, symptom monitoring, and tips and use of a message board. All the users agreed that the app was usable and it safeguarded their privacy and confidentiality, but it was unclear in their preliminary impact assessment whether the app use was actually more effective than control in improving asthma outcomes in this particular population. So here we saw with these interventions very low certainty and findings likely to change as new evidence emerges. So what knowledge gaps did our rapid review identify? Because of course, that is what happens when we do these reviews. We identify conclusions and findings, and then we also identify what's missing. What are some gaps? So what we saw here was that there is considerable variation across the studies with respect to the setting, the population, and the outcomes, and even within some similar intervention groupings. As well, there was inconsistency in the level of detail provided for each. So these inconsistencies may limit the generalizability of any findings and really highlights further the importance of context, which is something our previous speaker touched on as well. I think she said that context is often as important as the mitigation itself. And certainly here, that's what we saw, that the context is so important and that level of detail is certainly lacking. We also saw that there was a limited number of studies providing evidence for the experiences of populations who live with social and structural inequities. So people such as Indigenous, racialized, or rural communities, maybe those for whom gender and or mental health considerations apply. These factors were mainly addressed by studies evaluating the impact of evacuation interventions, but certainly limited across the other interventions. So further research is required, certainly to ensure representation of these populations for decision-making related to all the interventions. And then a third point here is that while our search was comprehensive, it is limited in that we didn't conduct a jurisdictional or gray literature scan. And we recognize that additional evidence may exist in these unpublished sources, such as program evaluation or regional data. So the conclusions that we can draw are that despite wildfire smoke events being a well-established and growing concern, there is limited quantitative evidence that rigorously evaluates the effectiveness or the unintended harms of public health interventions to reduce the impacts of exposure to wildfires and their smoke. We see that air cleaning systems likely improve indoor air quality. There was strong evidence to support that during wildfire events, but there is some evidence of harmful impacts of executing evacuation orders and for staying indoors without air filtration. As the frequency, severity, and the duration of wildfire events increase around the world, the burden on public health organizations to implement interventions and measures to mitigate these impacts will undoubtedly increase. So more research is required, taking a realist approach if possible, where research evidence is then paired with expert opinion and evaluation studies to really establish which interventions are most effective and under which circumstances. So again, getting at that context piece. So maybe I will pause there then and open up for any questions about our review.
Thanks very much, Robyn. We'll open it up to questions. Anything online?
Nothing yet.
Not yet. Eric.
Hi, Mike. Thank you for the presentation. Maybe just one question. You did raise the issue of equity issues in these interventions. Did you come across any studies that did try to identify barriers to the effectiveness of the intervention, or things that facilitated the effectiveness of the intervention? That may be on the scope beyond the scope of what you did, but did you see any of that, and what did that look like?
We found some evidence in the qualitative evidence, more specific around issuing evacuation orders, and how that impacted individuals within their community, how they felt that they had been impacted by it. And the equity piece then was which communities they were looking at. So was it interviewing some rural communities, interviewing Indigenous communities? So there was a little bit getting at what self-reported barriers were and what self-reported facilitators were, again, specific to that evacuation piece. but less so when it came to the other interventions that we included, that we studied.
Connor.
Thanks very much. Connor Reynolds with Metro Vancouver. My question is if you came across many references to heat and whether that was a confounding or exacerbating factor in the studies as these different interventions were being explored.
And that was heat was certainly part of our inclusion criteria. But I would say the majority, nothing comes to mind of one that was included specific to heat. They were really more about wildfire smoke, it seemed to be. But we didn't exclude based on that. So I'm not sure why we didn't find any per se. It mustn't have been looking at our outcomes of interest, perhaps. But that was part of our inclusion criteria. So we certainly looked for them.
Thanks very much, Robyn. I think we'll have to move on. Thanks again for presenting to us. So.